Hi, my name is Umesh Srikantha and this video discusses the planning and the surgical technique involved in minimally invasive resection of a C3-4 giant dumbbell neurofibroma with a significant intraspinal as well as extraspinal component. The case is that of a 54-year-old male who presented with neck pain radiating to the right upper limb for 6 months, associated with numbness since the last 5 months duration. Heaviness in the right upper limb and fingers was also present, along with difficulty in holding the objects due to weakness of the right hand. There was no difficulty or imbalance in walking, neither were there any bowel or bladder disturbances. On examination, he had a hypertonia of both lower limbs along with hand grip weakness in the right upper limb with wasting of small muscles of the hand. His power in the right upper limb, in the shoulder, elbow and wrist were around grade 4 along with hyposthesia in the right C5, C6, C7 dermatomal regions. Other limbs were normal as far as the motor and sensory functions were concerned. His MR imaging study showed a well-defined intradural extramedullary lesion at the level of C3-4 with an intraspinal component predominantly across the C3 and C4 vertebral bodies extending through the C3-4 foramen laterally into the extraspinal region on the right side. The extraspinal component goes anteriorly, laterally as well as inferiorly for as nearly as 7 centimeters from the foraminal level and was buried within the scalene muscles. The tumor almost had an homogeneous enhancement with some areas having intense enhancement as compared to the others. The surgical plan was to approach the tumor with a 22 mm tubular retractor and a double incision, the first incision in the paraspinal area to target the intraspinal and the medial foraminal portions, as well as the second incision in the far lateral area in order to target the extraspinal portion of the tumor. As per preoperative planning, this lateral incision was falling nearly 7 centimeters from the midline at the posterior border of the sternocleidomastoid in order for us to obtain a correct angle and trajectory to approach the extraspinal portion of the tumor. The paramedian incision to approach the intraspinal portion of the tumor was located at the level of C3-4, whereas the far lateral approach, which was located 7 cm lateral to the midline, was located at the level of the C4-5 disc space because the tumor was coursing inferiorly and laterally as it came out of the spinal canal. The patient was positioned prone on head pins. The intraspinal portion of the tumor was excised first with a paramedian approach. A 22 mm tubular retractor was docked after serial muscular dilatation onto the lamina of C3 and C4. Soft tissue cleared. The lamina of C3 and C4 were carefully drilled without causing any undue pressure on the underlying spinal canal. So after that, the extradural portion of the tumor was incised and then was decompressed using a CUSA. So this shows the nerve root along which the tumor is entering the spinal canal. The dura was incised along the nerve root or sleeve and was widened in a T-shaped manner in order to expose the intraspinal or intradural portion of the tumor. The arachnoid was dissected off from the tumor. Again, internal decompression was done of the intradural portion, and this intradural portion of the tumor was gradually delivered into the operative field without causing any undue pressure on the spinal cord. So the nerve root that was entering the tumor was identified, coagulated and was cut, and then the intraspinal tumor of the portion of the tumor could be completely resected. The tube was then directed laterally, part of the facet joint was resected, and the tumor that was lying in the foramen was again dissected, internally decompressed, and then was excised, thus disconnecting the extraspinal portion of the tumor and leaving that part behind to be tackled later by the second incision. The vertebral artery, which was situated at the anterior border of the tumor, was identified, dissected, and the tumor removed, with the vertebral artery being visualized clearly by the time the tumor was resected. The dural sleeve was reconstructed, taking stitches on either side, and the hole through which the nerve root was coming out, the enlarged portion, was covered with a dural substitute and the tube was then removed. For the extraspinal tumor excision, the far lateral incision was opened through serial dilatation. The soft docking was done on the portion that is overlying the C4 vertebral body on the lateral C-arm image. So after this, the tumor was identified, the muscle fibers were retracted, and sequential dissection was done in order to identify the lateral part of the C3-4 facet joint where the tumor was left behind from the foraminal portion that we had done through the intraspinal approach. So this area was dissected, the free margin of the tumor was identified, and this free margin was delivered into the operative field as can be seen in the image there. So once this margin was identified, the posterior-most fibers of the scalene muscles had to be transected in order to trace the tumor laterally and anteriorly into its extension in the anterior part of the neck. So after this, again serial pericapsular dissection was done for the tumor. The margins identified, internal decompression was done in order to sequentially dissect the tumor capsule from the surrounding tissues, and the whole tumor could be dragged into the operative field after sequential internal dissection and pericapsular dissection. Once the entire tumor was removed, the portion of the nerve root that was coming out from the tumor was again coagulated, cut, and the entire tumor could be resected in this fashion. Hemostasis was achieved in this extraspinal portion, and the tube was then removed. This is how the wound looked after the closure. Thank you for watching.